Health Academy, learning solutions for health professionals.
So today's session's about wound deterioration, what we need to consider. Sorry, I'll just get this slide going, set going. Okay, so really what this session, lunchtime session is about is whether we are identifying correctly the factors which may be impeding healing. So are we really seeing what we need to see and what we need to consider? And thinking about the importance of undertaking that holistic wound assessment. And I know we talk about wound assessment a lot when it comes to sort of the background of tissue viability, but how important is it really? Are you swabbing effectively? What interventions would you need to consider to understand why your wound may be deteriorating? And thinking about, some of our obligations and risks associated with not doing enough. So thinking about our clinical responsibilities, wound care is wound care is really looking at acute and chronic wounds and would be considered a specialty. Now, not that everyone needs to be a wound specialist, but we do need to have appropriate training and education to give us the knowledge that underpins our practice. And now, whether we're just sort of almost at an entry level where wound care is new to us, whether we've been doing it for years and we have acquired sort of more advanced assessment skills, or whether we are in that specialist role where, we have more acquired skills. We do need to think about the education, the knowledge, and the skills that underpin our practice, and particularly in some specialty areas such as like compression bandages, but also in things like recognizing the signs of wound infection or deterioration in a timely manner. And by doing that, we then fulfill our obligations under our sort of own accountability, and we also follow those ethical principles of non-maleficence, referring to our professional obligation not to cause any harm to patients. And that includes things like deliberate harm, risk of harm. So when we think about wound infection and deterioration, we think about that risk of harm. Are we assessing somebody's risk of harm? Are we recognizing somebody's risk of developing an infection and harm that may occur during the act of doing good? So we may be doing what we consider is good wound care, but are we missing something that potentially can put our patients in a situation where harm occurs because we haven't recognized things? So we do have to think about the sort of clinical accountability linked with what we're providing as far as wounds are concerned. So, um, so the factors that impede wound healing are quite extensive. So, it's quite a complicated thing. If you look at something like the picture that I've just put up in front of you, you can see that wound deterioration or things that impede wound healing, it's not just one simple answer. And hence why sometimes it can feel very frustrating. It can feel very overwhelming because you're seeing this wound and you're not really able to figure it out. So there's an awful lot of things that impede wound healing. So things like a lack of microvascularization, impaired cell function, cells that die off and don't do the job properly, lack of growth hormones, lack of cell movement, and the presence of things like protease, matrix modulators. And so there isn't one clear answer to why wounds deteriorate. What we do have to think about is, okay, what are we seeing and what can we do about that? So there, in the green around the outside, there are also factors that will sort of help to suggest what we would need to do. But we'll go into those in a little bit more detail as we go through the session. So if it's not all well at a cellular level, then the point of transition of a wound between the inflammatory phase and so the wound still has to go through its phases of healing. We've got the initial phase, we've got the inflammatory phase, we've got the proliferative phase, and then the maturation phase. And if things are not well at that cellular level, it doesn't move from the inflammatory phase into the real healing phase, which is the proliferative phase, easily. And we need to think about what is stopping a wound from moving from one place to the other. Now, one of the things that tends to be highlighted if you look at the literature around chronic wounds is the things, how metalloproteinases help to signal the functions that are essential for wound healing. So matrix metalloproteinases are in wounds the whole way through the healing factor. So if you look at the blue box below in the inflammatory phase, these proteases, which are protein digesting enzymes, they help to remove damaged protein. And in the proliferative phase, they help with angiogenesis, and they help with the migration of epidermal cells. And then in the maturation phase, they help with the contracting of scar tissue and that. So these proteases are really important. But when the wound fails from a cellular level to move from the inflammatory phase to the proliferative phase, meaning it gets stuck, what also gets stuck is the job of these matrix metalloproteinases. And we need to think about what do they look like for for you and I when we open a dressing up and we see a wound and we think, gosh, we're not really sort of getting very far with this, or it's getting stuck. So really, we need to think about what we see. And that's one of the most important factors of understanding what is blocking a wound's healing and what we need to do to move forward. So successful progression to healing requires a disruption of this cycle. And it requires us to support the wound to try and overcome what's keeping it in that inflammatory phase. So thinking about the bacteria because they're sitting there, thinking about what else is in the wound that may be resulting in overstimulation of this inflammatory response. So what do we need to do? Debriding the wound of devitalized tissue. So how can we clean up the wound bed? How can we do that within the knowledge that we have and the products that we have at the time? What do we do with regards to wound cleansing? Now, wound cleansing 15 years ago was a process by which we just cleaned debris out of the wound. That was what we did. It was kind of standard practice. But wound cleansing has evolved greatly, and we now talk about therapeutic wound cleansing. So we talk about wound cleansing that deliberately sort of cleans the wound bed and disrupts things like biofilms, and the objective of that therapeutic cleansing is to also disrupt those matrix metalloproteinases and get rid of all of the stuff that is sitting and taking up sort of squatting rights on the wound surface, and that is holding that wound in that inflammatory phase. And how we do that through the use of sort of pads or wipe, and also recognizing when a wound moves from progressing to healing to becoming over-colonized and maybe having a biofilm, or whether it then moves from there to a state of where it has active signs of infections. And what we do with that, what we do when we see that, looking at how we swab wounds, looking at our appropriate use of antimicrobial dressings. Are we using them for when we really need them, or is it a habitual thing that we just put it on because actually every time we take it off, the wound deteriorates, but actually we're not dealing with that deterioration in the first place? And do we recognize when wounds maybe are struggling with the microcirculation and the patient's aspects themselves? So if we think about it, then that, coming back to what we were saying earlier, that holistic assessment of the patient is really important. If we focus only on the hole that is in the patient, we miss all of those supporting pieces of evidence that may help us to create that wider picture of why this wound is not healing. So we have to look at the whole of the patient and not the hole in the patient. So thinking about all those elements that might influence why this wound is deteriorating or why it's not moving forward. So the comorbidities, the patient's general health, their nutritional status, all the things we know about. They're not going into in detail today because this is just a lunchtime session. But we need to think back of that. And who should carry out that initial assessment? Is the initial wound assessment being done by somebody who has got really good skills and knowledge in wound assessment, or is it being delegated and maybe due to staffing pressures or time pressures? And I get that that's what's going on out there, but actually, is the person doing that initial assessment the best person to do it? And we need to think about that, because if we do a really good initial assessment, we can set somebody up on a good pathway of care. What tools can help us to assist with that process, and what additional tools would be helpful? So that might be a case of, looking at what does our wound assessment documentation look like? Are we filling it out properly? Is it accessible to everyone? Is it transferable information? Are we communicating properly? Are we talking to the patients themselves about what their expectations and goals are? Because sometimes patients don't particularly want their wounds to improve. Perhaps it's from a psychosocial point of view where they actually enjoy coming down to the surgery or enjoy having district nurses coming to their houses because they're the only social sort of times that they get out. So being really clear and understanding what our patients' goals are and whether they align with ours, and really, how do you meet together in that? Honest and effective communication. If a wound isn't likely to heal because of comorbidities, then we need to have that honest conversation. If patients are smoking, we need to be honest with them about how that is having an impact on the movement of oxygen through the tissues, how we need to be talking. And then, as I said, that communication factor, I will keep talking about communication because it's a huge part of it. And then it is about identifying what tissue is present in the wound bed itself and looking at, that tissue and what are we going to do with it. So if it's necrotic, are we able to debride it with what we have? Is it the right wound to debride? Or are there other factors that we need to consider for safety wise? Can we recognize the presence of biofilm? And this is where the whole aspect of therapeutic cleansing comes into place. Most chronic wounds, the literature will say that 75% of chronic wounds will have a biofilm. So, they might be wounds that you see on a day-to-day basis and you think they are just not moving forward. They're not really infected and everything we're doing is good wound care, but I'm just not winning with them. So think about, even whether, some people will argue that biofilm is visible, some people argue that it isn't visible. So, actually, is it worth starting a biofilm targeted care plan for a couple of weeks and see if that has an impact? That would be something like soaking a wound bed in a Prontazan solution or octenolol, depending on what's on your formulary, for 5 minutes, using a debriding pad, whichever one is on your formulary, your debris softs or your UCL wipes, and actively therapeutically cleansing the wound. So we're talking about literally wound exfoliation within the patient's tolerance, pain tolerance, and also within the wound fragility tolerance. So obviously we don't want it to bleed too much. And then are we supporting that initial sort of recognition of biofilm with antimicrobials for maybe 2 to 4 weeks? And is the same person reassessing it the next time? So there's no point in starting a care plan like that where 3 or 4 different people are going to see the wound in the subsequent dressings, because then the person who initiated that doesn't see the benefit and outcome, and then decisions get fragmented. So, or even set a review of, this is the care plan, we're going to do this for 4 weeks, and in the fourth week I will review it because I've recognized that thing. And that's really, really important, where we may have to have targeted specific reviews because we've put a care plan in place. And think about, the benefits of that targeted biofilm thing. So for example, just a quick example of a targeted biofilm program, this wound in the middle, which is on the heel. I don't know where my thing is. So the wound on the heel with a bit of necrotic tissue in the middle. This was that's the difference between 2 weeks of a targeted MMP soakage for 5 minutes, a targeted debridement of the wound with a debridement pad and an antimicrobial, and that was done twice a week for 2 weeks, and you can see the significant change. So it is worth doing if you've got old wounds that are just sitting there and you're thinking, gosh, we're not getting anywhere, and your objective or your assessment is that they should heal, that there's nothing holding it. It is important when you do that assessment that you've made the decision, despite this person's comorbidities, despite their nutritional, despite this, they should heal. Then we should be seeing a change. So that's when something like a biofilm plan is worth doing. And just to give you an idea again of how effective it can be, this was a photograph taken 1 week between each other, and it was literally a targeted biofilm, and that dressing was done. This was obviously not in a GP surgery, but it was in a home, and the dressing was changed once a day. And in that, it was targeted Prontosan soaks, Debris Soft pad, and an antimicrobial. And you can see the significant difference within 1 week because we targeted that program. We targeted that biofilm. We targeted that dead tissue with it. And that wasn't sharp debridement. This was just normal nursing home activity, wound activity with a guided good care plan. So it can be achieved. So we need to think about that. And we need to think about those other wounds that maybe that we need to have that um, um, uh, high risk hat on for. So thinking about diabetic feet ulcer, we shouldn't be sitting on diabetic foot ulcers at all. I think the real thing for me, which is a colleague of mine who's a vascular nurse specialist, once said to me, she said, when you have a diabetic foot, think about redness with wet necrotic tissue, think about infection, redness with dry necrotic tissue, think about ischemia. And I've always held on to that if when I'm assessing a diabetic foot. And I think it's important that we never sit on a diabetic foot and think, oh, I'll check it next week when I come back because, we'll see if it's improved. Because the truth is that a diabetic foot can go off and lead to an amputation within 5 days. So that's super important that we do that. And also, are we managing our moisture properly? So I'm just talked about biofilm there for a second. Now we need to just think about the moisture side of things. So are we really looking at our managing our moisture level properly? Because the fact is that if we don't manage moisture in old hard to heal wounds, then we are setting ourselves up to fail and we're setting the patients up to fail. Moisture management to me as a tissue viability specialist was always the key, one of the key factors to reversing, a wound's trajectory. I know there are some wounds out there that you may never manage the moisture because maybe of patient compliance and that, but certainly for the ones we can do, we should be. Now that might involve changing things like foams to super absorbent, so we're getting better absorbency, or it might be changing the frequency of our dressing changes for a short period of time to manage that wound, the additional wounds. But that is super important. If there was anything that I could say to you is that if your patients are coming back at all with the dressing soaked or the strike through on the foam dressings out to the edges of the foam, then the chances are the wound bed is oversaturated. And if it's oversaturated, it is a holiday environment for bacteria and biofilm, and we're on a losing streak. Looking at wound swabbing, it is also really, really important that when we do think there's a problem, that we get the best information possible. So we all have learned different swabbing techniques over the years, and swabbing techniques have changed, and we've all done sort of clean it beforehand, don't clean it beforehand, do a zigzag, swab the bits that are really necrotic and dirty. But actually the Levine technique, which the world it the the World Infection Consortium agreed was the swabbing of choice. It's called the Levine technique. And what it is about recognizing that if the wound has an infection, it's usually because of the activity of bacteria in the wound bed itself, not sitting on top of the wound bed. So basically, we need to find a clean part of the wound. So we clean the wound of all visible debris. We need to find the cleanest part of the wound. And then we take our swab and we press into the wound bed on that clean part. So what you're asking the wound to do is you're looking to squeeze out some fluid from the cells in the wound bed itself. And then you twirl the wound swab to collect that and then send that off. So you are taking a specimen of the exudate that you freshly squeeze out of a clean part of the wound bed. So you are sending away something that will allow you to see what bacteria are actually in the wound bed itself, which is more likely to show up the ones that are causing some problems. And do we do baseline observations? That's one thing that's really important. I was involved in many safeguarding incidences over my career in tissue viability. And in most of those, it was clearly noted that even though it was recognized that the wound was infected, we actually didn't take baseline observations. And wound infections can cause sepsis. So that's really important that we do keep our basic nursing things so that we're able to do things like muse and look at that, and then also think about how pain might be linked to that wound deterioration or be one of the reasons why the wound is failing to progress. Maybe, and pain is very unique to people. It's very subjective. You can have very large wounds with little pain. You can have tiny little things where people won't. And maybe work with the patient to improve engagement, especially when pain is an issue. So maybe making sure that we get them referred back to the GP for a reassessment of their pain pathway, maybe get the pharmacy to do a look at their medication, do a medication review, or maybe even let the patient help themselves. There's absolutely no reason why a patient can't wash their hands, put a pair of gloves on, and take their own dressing off if that makes them feel less anxious and stressed. So do think about the pain element and whether that is one of the barriers to you achieving effective um, um, forward motion in the wound healing. And then think about gravity. I think this is one of the really key things. And this is a classic picture of mine, which I do have permission to use from a patient. And this shows how before I got the referral, this was my first visit to this gentleman. And when I took his dressings off, this is what I saw. So the bottom part of this wound is healthy and granulating, but the top part of the wound is covered in biofilm. And the reason that that is happening is that because when a hydrofiber absorbs fluid from the wound bed, it turns into a jelly and then gets heavy. And then when we do our dressings, we have patients lying down flat. So it's all perfectly packed in there and very neat and tidy. And then we put the secondary dressing on top and then they stand up. And then the dressing becomes filled with fluid, it becomes jelly-like and it gets heavy and it falls down into the bottom of that wound. So how can we make sure that the wound, our primary dressing is staying tucked up to the interface of that wound. So we want the primary dressing, the first layer dressing, to be up against the wound bed. And often with these, I would line this with just a one sheet of a hydrofiber, whatever was on the formulary, and then I would use unraveled gauze from the sterile dressing pack, and I would use that to fill the rest of the cavity before I put my super absorbent dressing on. Make sure that we're recognizing skin stripping from exudate levels or reactions to dressings as well. So dermatitis caused by allergies. Make sure if we're using things like PB7 that we have done a patch test for PB7 as well. And think about what other tests you need to carry out. And these should be done almost as norm. And I think we should also always have a baseline when a new patient comes in with a wound, especially with a wound that is greater than 4 weeks old. where it sits into that hard to heal sort of factor. Um, do we do a blood screening on them? Do we do a full blood count, UNEs, LFTs? Do we look at their serum albumin levels? Do we get a baseline blood works picture on them? And then if they deteriorate, are we repeating that? Are we looking at those inflammatory markers? Are we seeing if they have low serum albumin, which might suggest that they have malnutrition or they've got hypoproteinemia? And that will have a profound effect on things like the management of fluid within your tissue and possibly lead to poor healing. Are we looking at their blood sugar picture, and referring them back to the specialists if that is out of balance? Are we actually also, and I know the pro PNB, which is for heart failure, is an expensive test, but they're actually, the statistics are that about 30% of patients with heart failure go undiagnosed, and that heart failure could have an element that is affecting their ability to heal. Are we doing ABPIs? Now, ABPIs are not just for leg ulceration. They're not just to decide whether you're going to put compression bandage on. We should be doing an ABPI to assess somebody's ability to heal a foot ulcer regardless of the etiology. Now, obviously, if you've got somebody with very low and symptoms of ischemia, you don't want to be putting a blood pressure cuff on and doing an ABPI because yeah. But for everyone else, if they've got a heel pressure sore, if they've got a leg wound, if they've got toe wounds, if they've got wounds on their feet, we should be assessing how good the blood supply is to that, because that then gives us a level at which we can think about the possibility on the probability of healing, or even that they need referral elsewhere. So do think about those elements that, I know time is a factor, and I know it's really difficult to do an ABPI even when you're just trying to get somebody into compression, but think about the benefits of knowing the blood supply, and the potential effect that has on the patient's outcome. And also, if a wound has resulted in the exposure of a bone, especially when wounds are in areas that are superficial, so things like your ankle bone or your elbow or the toes, or the bunion area, and that. If a bone gets exposed, it has the potential to also become inflamed, and that's called osteomyelitis. And usually it's confined to that bone area that's been inflamed. But if we've got osteomyelitis, it is unlikely that we are then going to be able to get healthy granulation tissue to sit over and attached to a bone that's inflamed. So we need to have a look at that. So we need to think about asking the GPs or getting an X-ray done of that area, and maybe doing some blood markers to make sure that their inflammatory markers aren't up. And do trust your instincts on this. I've had to send patients back again and again saying, I know they have osteomyelitis because I know that this wound should heal. And eventually they've ended up having some surgery done to remove a bone that's an osteomyelitic bone. And within weeks after that bone's been removed, they've healed up beautifully. So do think about that as a possibility there. And then think about the effects, consider the effects of medication and polypharmacy, because again, that could have they could have an issue as to why wounds are delayed or why they deteriorate. So think about sort of anti-cancer drugs, because they target rapidly dividing cells. Think about the patient's pre-existing conditions. Maybe they're on anti-inflammatories, they might be on oral steroids, or they might use over-the-counter anti-inflammatories. People forget that, our ibuprofen that we pick up from the counter thing can actually have a knock-on effect on wound healing. So especially if somebody is regularly taking anti-inflammatories, over-the-counter anti-inflammatories, I mean, the research and the general feel in the literature at the moment is that if we have a new wound, so say if somebody gets a laceration or we get muscle damage, we should actually avoid using anti-inflammatories for the first 7 days, because the body needs to recognize it needs to be able to move naturally into that inflammatory process of wound healing. And by using anti-inflammatories, we might be dampening that down. So please do, ask them about their normal use of anti-inflammatories. With anticoagulants, luckily we're seeing less people on warfarin, but warfarin can cause skin necrosis. So do ask about that. Immunosuppressants can inhibit the DNA synthesis and cell replication. Colchicine, which is for gout, can inhibit cell shape maintenance. So if they're on colchicine, they might struggle to heal the wounds. It might be that they have to come off that for a while. Corticosteroids we talked about. Antibiotics can cause some. They can help. Some of them can help, but some of them don't. And it is always really good if a patient, especially if they haven't seen a pharmacist for a while, that they have a medicines review, because some of those tablets or the interactions in those tablets might be something that is influencing. And some antihypertensives like ramiprofil can help do block healing, but some other ones can improve it. So you can talk to your pharmacist about that. They'll have more information on that. So, and then finally coming up sort of towards the end, because I realize how small this session this is, and I want to leave time for some questions, is do think about the timely referrals. Apologies for jumping forward. So, don't sit and wait and see, oh, I'll wait for a couple of weeks and see if it improves, because in the system that we're in at the moment, everything is delayed. So if we get to a point where we think, gosh, I definitely need to refer them to the tissue viability, maybe I should have done that a few weeks ago, then it's going to be another X amount of weeks before that referral gets thing. And with some of the consultants, maybe even longer. So if we feel, if we trust our instincts and think, actually, do you know what? I'm going to refer them now, and then I'm going to manage it because I've done my assessment. I'm going to manage it in this way. And if it doesn't improve, then and we can always cancel referrals. It's much easier to do that than to have them wait another 6 weeks in the system. So think about that. Vascular referral, if there's arterial disease, if there's prominent varicose veins causing symptoms, or if somebody heals with their leg ulcer and then it recurs and it heals and recurs, then send them to vascular. We should be sending 90% of our, hard to heal vascular leg ulcers to see if they could benefit from their varicose veins being stripped. If it's a very large hematoma, we might need a plastic referral. So it's better to refer them to plastics early and then manage the hematoma, and because they may need some skin grafting. If it's a dehisced abdominal wound, then we need to refer them back to the consultant or tissue viability to help with management. Think about the palliative care team for fungating wounds, and the diabetic podiatrist, or even the vascular nurse specialist if it is a vascular sort of arterial wound. And of course, the dietitian for malnutrition. And if we look at the blood test that we were talking about doing earlier, if we've got low serum albumin levels, do consider asking the GP to supplement somebody just for a short period of time. I think sometimes when we talk to GPs and doctors about supplementing, they think, oh my God, this patient's going to be on, nutrient supplements but actually if we go to them with saying, look, this patient has low serum albumin, this patient's wound is deteriorating, they've been through a hard time, they're really not eating well, they're very low. I think if we supplement them for 4 to 6 weeks, and then we will review it, then that will give them the boost they need to give them the extra proteins, calories, and vitamins that they need. And I used to supplement a lot of my hard to heal wounds for short periods of time to help them, especially if I'm debriding, especially if I'm dealing with heavy biofilms and lots of devitalized tissue. And also remember to update yourselves with the current recommendations and guidelines. So you may have been aware of the Wound Care Strategy Program, the National Wound Care Strategy Program. They did recommendations for care on surgical wounds, on leg ulcers, and on foot ulcers and other things. That has now moved to the Health Innovation Centre, which you need your NHS thing to log in. So do make sure you're up to date with the current guidelines and procedures. And just to round it all off, it's just to say that 59% of chronic wounds healed if there was no evidence of infection. So there is data out there to say that if we manage chronic wounds well, other than those that have the that are deemed as never likely to heal, that if they have no evidence of infection, that about 60% of them will heal eventually. But compared with the 45% that healed if an infection was present or suspected. So we've got the opportunity to deal with that additional 45% that didn't heal if we recognize and deal with signs of infection and think about from an early stage, what do we need to do to move this along. Health conditions can predispose people to wounds that are difficult to heal. So we need to recognize how those health conditions affect the healing and have those open and honest conversations with patients about, yes, they may heal, but actually it might take an awful long time, and they need to be your partners in care. And in clinical practice, it is about wound assessment and looking at all things. So that's a short lunchtime session for you. So if there's any questions, I would be happy to take them if you want to either unmute yourself and ask, or if you put them into the chat, then I'm happy to answer those questions. If not, we've got a few minutes. The girls will be putting a link in to say that for some feedback. As I said to you earlier, I'm a newly qualified nursing associate. Is there any other training offers? Struggling to find some at present. So please, could you send me this slide? So Rachel, the Girls from Health Academy will send you some details of wound care training that I do that you might be able to access yourself. Thank you very much for that feedback.